So that brings us really to the practical implementation question of all of this. Clara Saldarriaga will actually tell us.
So thank you very much. So after those wonderful presentations, I'm going to wrap the session with a clinical case. I hope you like this case because it's what we see in the real world. So those are my disclosures. So let me start telling you that when we see our patients every time at the clinic or at the hospital, so we have the chance to change the evolution of the disease. So this is my patient. It's a 79-year-old man with a past medical history of non-ischemic cardiomyopathy that was diagnosed 1 year ago. His ejection fraction at this point was 20%, and he was in New York Heart Association Class 2. As you can see here, most of our patients with heart failure, they have other diseases. So this patient also had type 1 diabetes and also chronic kidney disease stage 4. Here you can see the prior treatment of this patient. He was just receiving beta blockers and ACE inhibitors. He was on furosemide and insulin for his type 1 diabetes. So then this patient was admitted to the hospital due to signs and symptoms of congestion. As you can see here, this is the typical definition of a worsening heart failure patient. So we admit the patient, we look for the cause of the decompensation, and then we treat these patients with IIB diuretics for 4 days. And after that, the patient is stable on the ward. Now we switch the patient from IV diuretics to oral diuretics. And here you can see the blood pressure, the labs at that point of the evolution of the patient. And now let's decide what to do with this patient. How are we going to improve the prognosis of this patient? So here I have the 3 most important patients that we always had with a patient like him. When to start the treatment, how to up-titrate the treatment, and finally, what to expect when we start heart failure medications. So as Shelley showed before, we are convinced that now the moment to start the medications on a patient like him is the hospital. So you see all the trials that involve patients that were admitted to the hospital, and how can we improve the prognosis if we start early and if we improve the treatment of the patients at the hospital. So let's move back to my case. So here I have several options to consider in this case. So maybe you are thinking, why not to switch this patient from the ACE to an ARNI? But here you can see that we have 2 limitations. One is the kidney function of this patient, and the second one is the potassium. Then we have the MRAs. This patient was not receiving MRAs, but again, we are facing these 2 problems, potassium and renal function. Or why not to start an SGLT2 inhibitor? But remember that this patient has type 1 diabetes. And finally, as I mentioned before, this is a perfect worsening heart failure example. So this patient has a new option, as Shelley just showed, so we can start this patient on vericiguat. So let me show you this very practical graph from a Canadian Cardiovascular Society of Cardiology. Actually, Shelley is one of the main authors of this. This is a clinical practical update of what to do with a patient with worsening heart failure. And here you can see that we have green, yellow, and red lights when we are trying to start all the medications in those patients. So let's review our patient. As I mentioned before, this patient has green lights for beta blockers, so we can keep this patient on the beta blockers. MRAs, red lights, as I mentioned before, also for ARNI and for SGLT2 inhibitors. But if you see, this patient has a green light to start vericiguat, as I mentioned here. And I just want to remember the red lights when you are going to start this medication. So patients that are on long-action nitrates are not good candidates for that. Also, those that are receiving some other medications from the same family than vericiguat. So, and also those patients with NT-proBNP higher than 8,000. So now we have an option to improve the prognosis of this patient. This is another graph that I want to show you just to remember that those patients with worse renal function, those between 15 and 30 glomerular filtration rate, they had been excluded for most of the heart failure trials. But we have evidence with vericiguat down to 15 millimeters of glomerular filtration rate. So this is something good that we can also improve the treatment of those patients with poor renal function. So let's face my second question. When we know that this patient is ready to start medications in the hospital. So here you can see 3 things that are common elements in all the trials that Shelley showed about when to start medications in the hospital. So if the systolic blood pressure is more than 100, if we have a stable renal function in our patients, and if the patient is non on IV vasoactive therapy, so that's the right time to start medications in the hospital. So this is what we do with this patient. So we start vericiguat 2.5 milligrams. So now let's move to the second part of this. So we need to up-titrate the medications. So we are really convinced that it's important to up-titrate the doses of the heart failure medical therapies. Here I'm showing you the results of the STRONG-HF trial. And you can see that when we up-titrate the doses of the medications, we can get a reduction in the events of those patients. So this is what we do with this patient. So we also up-titrate the doses of vericiguat using the Victoria trial protocol. So every 2 weeks, we increase the doses of the medication up to 10 milligrams. So sometimes we face these 5 problems in our patients. So we need to deal with renal function, as I mentioned before, also with hyperkalemia, with hypotension, and with some patients that are really tricky when we are trying to start heart failure medications. Older patients and patients with lower body mass index. So let me show you what can we expect when we are starting vericiguat in patients. So here I'm showing you this very interesting analysis from Caroline Lamb about those patients that we are really afraid of when we are starting a medication. So this is the analysis from Victoria of patients that were older than 75 years old with lower systolic blood pressure and with the concomitant use of sacubitril valsartan. And as you can see here, the reduction in blood pressure was similar in the placebo group versus the treatment arm. The decrease in the blood pressure occurred just at the beginning of the treatment. It was a minor reduction. As you can see here, that by the time, even blood pressure increased in the treatment arm. Just to remind you that 90% of the patients, more than 90% in the Victoria trial, were up-titrated to 10 milligram doses of the medication. And here you can see what happened with the glomerular filtration rate. So no changes in the glomerular filtration rate with the use of the medication. And also, the electrolytes are not a problem when we are starting or up-titrating this medication. So let me go back to my case. So this is what we do with this patient. We start this patient on vericiguat. We up-titrate the doses to 10 milligrams. We also look for iron deficiency in this patient. This is also important. We refer the patients for cardiac rehab, and we are following this patient in our clinic. And now he's at home without new hospitalizations. And we are very happy because we made the wise choice in this patient. We improved the treatment, and we understand that worsening heart failure is an opportunity to change the evolution of the disease. So let me summarize with these final slides about when to start vericiguat in hospital or at the first follow-up visit or in the outpatient setting. And those are the practical points on when the patient is ready to start the medication in the hospital. And finally, in this slide, you can see all the treatments that we have for heart failure, how vericiguat fits in this population of patients with worsening heart failure, and how we need to make sure that the patient is on all the things that we have to improve the prognosis. So thank you very much for your attention.